Welcome, everyone. My name is Teresa Wickerham, and I'm the facilitator for the St. Louis Thyroid Cancer Support Group. So I'd like to welcome you and hope you enjoy your conference this weekend. This session, for those of you who, just to make sure that you're in the right session, is right up here on the screen, Novel Chemotherapies for patients with metastatic papillary, follicular, or Hurthle cell thyroid cancer. And our speaker today is Maria Cabanillas. She's an endocrinologist, assistant professor in the Department of Endocrine Neoplasia and Hormonal Disorders at the University of Texas MD Anderson Cancer Center, Houston, Texas. Her clinical focus is metastatic thyroid cancer, and her research interests include targeted therapy for metastatic thyroid cancer, as well as supportive care in cancer. She is a graduate of the University of Puerto Rico Medical School. She completed a residency in internal medicine at the University of Texas Health Science Center at Houston, Texas, and a fellowship at Baylor College of Medicine, Houston, Texas. She has authored many peer-reviewed journal articles. Welcome.
All right, so I am going to talk a little bit about. I'm going to give you a little bit of background of these different thyroid cancers. But what I really want to do today is to help a lot of you understand how we're able to interpret what is being published, what trials are out there, what drugs are available for this disease, and who are the patients who should be treated for this disease with these novel chemotherapies. Okay, so you probably all know that differentiated thyroid cancer incorporates the papillary, follicular, and Hurthle cell cancers, and that's the majority of thyroid cancers, and then a minority of patients have medullary and anaplastic. So the standard therapy starts with surgery, then radioiodine, and then thyroid hormone suppressive therapy, so you're on higher doses of thyroid hormone, and then observation. And then these steps can be repeated if you need further surgery or further radioiodine. And we always, just as an aside, I don't know, I see a lot of patients that really don't know what thyroglobulin is, so I kind of throw it in here because there wasn't a better place to put it in. But thyroglobulin is our tumor marker for differentiated thyroid cancer. And we, essentially it's made by thyroid cancer and normal thyroid tissue. So we follow the thyroglobulin levels because it helps us to understand whether the disease is coming back, getting worse, getting better. Okay, so today I'm going to talk about the chemotherapies that are available really for patients who no longer take up iodine. And so those patients are called radioiodine refractory. And so what that means, and there are many definitions, I'm not sure that we've come to a consensus on what exactly it means, but my definition is that you have at least one tumor that we are fairly certain is thyroid cancer, and that it doesn't take up iodine. So you might have some that do and some that don't. Or it could be a patient whose tumor grows despite taking up radioiodine, and that would be within a year. And then a patient who's received 600 millicuries or more of radioactive iodine because we don't really believe that there's much of a benefit past that dose. And it can also be harmful to the bone marrow and cause other problems. So the prognosis is it's kind of a tricky disease, right? I think this is a pretty straightforward way of understanding it, because most patients have what we call indolent disease, meaning it grows very slowly, behaves well, prognosis is really great. And those are usually the younger patients with small metastases, okay, less than a centimeter. They're the ones that have the best prognosis in metastatic disease are the ones who have lung only, and their survival is usually measured in decades. The ones that also have a good prognosis, but maybe not as long as the young patients with small volume disease, are the young patients, again, with larger disease, lung only. And then the older patients with small volume disease also have a pretty good prognosis, but the older patients, and older in this manuscript paper that was published was 45 years old, they have, 40 years old. they have larger disease, and they have not only lung, they could have multiple bone metastases, they have larger volume disease, and their survival is shorter. And these are really the ones that we were mostly concerned about when we're thinking about starting one of these chemotherapies. Prognosis is also related to whether it takes up iodine, whether it takes up on a PET scan, and the type of thyroid cancer also makes a difference. And we'll talk about that here. So papillary, the well-differentiated papillary folliculars, those have a better prognosis than the patients with the poorly differentiated or anaplastic patients, right? So, so we're also, we get a little bit more concerned about these patients here, and maybe have a lower threshold for going ahead and starting on systemic therapy. So this is an example of a young patient with a very good prognosis. Patient was diagnosed at age 17, okay, and now the patient's 53. She takes up iodine, and she's still alive after 36 years. So these are the patients that fall into that category that do very well over time. Those patients probably, we need to think long and hard about putting those patients on therapy if their disease is not really causing them any problems. Prognosis also relates to whether you take up iodine or not. So this is a survival curve, and I put it up here also so you can start to understand what these curves mean. Essentially what it means is the patients up here, right, their overall survival, that half the patients are still alive after, well, actually they never even reached the median, but here at 50%, half the patients are alive at this number, and half the patients would be alive at that number had it reached it. So essentially, these patients live a very long time, and these die sooner because they're radioiodine resistant. Patients who take up FDG on PET scans also tend to have disease that progresses faster and is more aggressive. So these PET scans help us to understand the metabolic rate of the disease. And what that means is really how fast is it metabolizing sugar. And so if you see a lot of black where the tumor is, that is a tumor that metabolizes a lot of sugar, meaning it's probably going to grow faster, it's going to be more aggressive disease. So other prognostic factors that are negative, meaning that the prognosis is worse, are older age, any site other than lung, and then symptoms at diagnosis is also really important. So the patient that presents with shortness of breath on diagnosis of thyroid cancer, those patients have usually more aggressive disease and may require systemic therapy sooner rather than later. So there are 3 treatment approaches. The first is to just watch and wait, okay, because we're trying to differentiate who are the patients who have aggressive disease and who are the patients that live a very long time even with metastatic disease. We then consider doing localized therapies, meaning we do a short course of, for example, radiation. We might be able to shut off the circulation to the tumor with embolization. We might be able to do surgery on some patients that have maybe just one or 2 sites of metastasis, that we can just remove those and watch everything else. Those are usually limited situations, but these need to be considered, right? Because systemic therapies are chronic therapies. You really don't stop those unless they're no longer working. And so if we can do something to stop some areas which are causing problems with these types of therapies, then we can delay having to start systemic therapy. And then the third treatment is systemic therapy, which we're going to talk about now. So why do we do watch and wait? Well, there are quality of life issues, really. You don't want to put a patient on chemotherapy, expose them to many side effects if you're not even able to cure them. And so far we haven't really cured anybody that I know of with these therapies. So we need to be careful about who we decide to give them to. Localized therapies can include doing surgery, again, giving patients external beam radiation to the neck if they need that. We can radiate lung metastases if they're just 1 or 2. Possibly take one out if there's just one that's causing problems. Bone metastases, we like to radiate mostly because these therapies, these newer chemotherapies, don't work great in bone, and so we like to target those with radiation. We can also take them out, basically surgery, and these patients, not everybody should be, but the majority of them should probably be on one of these drugs, which is Zometa, zoledronic acid, or denosumab, which is Xgeva. And these can also help with pain control and bone metastases. Brain metastases require surgery or radiation, and then liver metastases can also be treated with surgery, embolization, which is shutting off the blood supply to the tumor, and other therapies. So these are the patients who should be treated, right? The patients who, despite radioiodine, the tumor's growing, they may have large metastases that are going to get them into trouble. For example, a very large lung metastases or pleural fluid in the lungs, which could cause them problems with their breathing. They need to be healthy enough to undergo treatment because these treatments have side effects, right? So we don't want to put a very sick patient on these therapies because they're not going to be tolerated very well. And sometimes that's tricky to find the moment where the patient is progressing, but they're still well enough to be able to receive these therapies. So you don't want to wait too long and then miss your opportunity to start them. So it is, it is rather tricky. The patients who have a lot of uptake on a PET scan, you could consider, this can play into your considerations, but I don't think it should be the only reason to start therapy. Yes, go ahead.
A lot of uptake on a PET scan, or you just...
I was talking about patients such as this that I showed here. So this patient has a lot of disease here in the chest, and it is very, very much avid on PET scan. So this patient is probably going to have pretty aggressive disease. They're probably going to need some therapy soon, but it should not be the only trigger to start therapy. Okay, so this is just a summary. We start with suppressing the TSH, observing the patient. Can they receive more radioiodine, localized therapies, and those include the list here that I discussed. Bone modulating drugs are the Zometa and the Xgeva that I discussed. And then we ask ourselves, okay, are things still progressing? Is the patient symptomatic? Does it no longer take up iodine? And then we consider the kinase inhibitors. Okay, so just so you understand how to read the literature, in case anybody's interested in reading these studies, it's really not that difficult. Okay, so I'm just going to go through it, and if you don't understand it, you don't really need to understand it, but and I'm happy to answer any questions. But so basically, these are the things that you need to know. You need to know what RECIST criteria are, waterfall plots, what tyrosine kinases are, and the different types of trials. And that's what we're going to go over. So RECIST is essentially a way that we standardize measuring whether a patient has a response to the chemotherapy or not. Because if you ask me, my patient, is he responding to this therapy, and I just give you my subjective opinion, well, that's not very helpful because we have to have some way of measuring to know whether the patient is really responding to the therapy and benefiting from it. So we first start by looking for what we call target lesions. And target lesions are usually more than a centimeter in diameter. What we do is then we take those different tumor sizes, we add them up, and that is where we start. Okay, and then subsequently we keep measuring those same tumors to see whether they're getting better or worse, or staying the same. And then we talk about non-target lesions, which are basically disease that is too small to measure accurately, and that's usually less than a centimeter. Something that's previously been treated we don't want to use. And then bone metastases are usually considered non-target lesions, but we need to keep an eye on these things, right? Because we need to make sure that they're also in control. So these are the definitions of response. Complete response is basically that all the tumors go away and your thyroid globulin normalizes. A partial response would be an increase of 30%, right? So we look at the very best response, and if they've met the 30% mark, then we call those partial responses. Progressive disease is that it grew 20%, and stable disease is anything in between those two. Okay? And I'm going to show you how this looks on a graph. So this is just an example of a patient who had this tumor that we measured as a target lesion, and then we measured it again after therapy, and you can see that it's smaller, right? So then, and we add up all the other target lesions, and we make these comparisons, right? And then we plot it on a graph. So this is what our waterfall plot, our graph looks like. You'll hear waterfall plot a lot, and so you can just open some of these papers and look at them yourselves. Progressive disease is basically it's going up on the graph, right, over the 20% mark. A partial response is under 30, is a greater than 30% decrease, and then a complete response is 100%. But I put maybe in here because they also have to have a thyroglobulin response. So basically, the TG has to disappear, or else it's not really a complete response. So this you have to question when you see it. And then stable disease is everything else that lies in between. And you see that some patients, didn't quite make it, but they were pretty close. It's just an arbitrary cutoff. But you need to understand this, that stable disease is not necessarily a bad thing. It just doesn't meet that 30% cutoff mark. Okay, these are the different types of trials. We have phase 1 trials, which are usually first-in-human trials, but they can also be drugs that you're trying to combine. So I want to combine Sorafenib with everolimus. I don't know what the dosages are that are going to be safe, and I'm going to put them together in a trial, and I'm going to figure out what the right dose is. A phase 2 study is basically you're going to test efficacy. So you want to know, does the drug work in this particular disease? And these are usually trials that are smaller. They're usually somewhere around 50 patients. Phase 3 trials are large trials. They're the gold standard. Basically, this is what you need to get a drug approved by the FDA. And they're usually randomized to treatment or whatever the standard of care is. So if your standard of care is observation, then you would randomize to a placebo. If your standard of care is now Sorafenib, then the FDA might ask you to randomize Sorafenib plus your new drug. Does that make sense? Okay. So those are the best trials because they're large populations of patients. They're usually in many, many different centers. Yes, go ahead.
Based on the slide that you just showed before this, I was under the impression that once you're on TKIs, that your thyroglobulin may not be so reliable.
That is not necessarily true. We do see a nice correlation, and it's not 100%, right? That's why we don't say just because your thyroglobulin goes down that that's a response. But usually thyroglobulin responses correlate, they track with the responses on the CAT scans. This is just what complete response means, though, is that everything has to go away. All the bad stuff has to be gone. Okay, so that's just the definition. Yes?
What is the proper thyroglobulin marker?
I'm not understanding the question.
Your thyroglobulin has to be
Undetectable, basically.
okay, that's what
Undetectable, yes.
Undetectable.
It has to go away. Okay, so what is a tyrosine kinase inhibitor? This is kind of we use this as a label for lots of different drugs, although they're not necessarily all tyrosine kinase inhibitors. We kind of use that term for most of them. That's probably the one that you'll hear the most, which we call TKIs. And basically what it is a type of chemotherapy. It's not necessarily always a pill or always an IV, but they're usually pills. And they basically prevent the phosphorylation, which is the way these cells communicate with each other to help the tumor grow. Okay, we also call these multi-kinase inhibitors or kinase inhibitors, and so they usually refer to all of these newer types of drugs that we're using now for thyroid cancer. Cytotoxic chemotherapy, it's the old kind of chemotherapy that you think of, where your hair all falls out, and breast cancer patients usually receive these types of drugs, when they're before they're going to go to surgery. And we use these drugs in thyroid cancer in the past. They're not used very much anymore. The only one that's actually approved for thyroid cancer is doxorubicin, and it was approved in the 1970s with very little evidence that it worked. We didn't have these very rigorous trials and standards that we have now. Other drugs that we use are paclitaxel and cisplatin, but really the response rates are pretty low. They're not very durable. They don't last very long. And there's really not enough data to say whether they're effective or not. So most of us have abandoned them. There are a few cases where you might want to use these types of drugs. So a lot of people talk about personalized therapy, and basically what that means is that you're trying to identify some type of target in the tumor and get a drug that goes against that target, right? Match up the drug against whatever abnormality that the tumor has, which is allowing it to grow. And so this part of the talk is not essential to really understand. But if you're interested in knowing a little bit more about how these drugs work, this is kind of a very simplified overview, and it's not important for you to know this. I'm just putting it out there for people who want to know a little bit more. So one of the things that we target is the blood supply to the tumor. These tumors oftentimes have a lot of blood supply. They're usually these tortuous vessels that supply the tumor with nutrients. And so essentially what happens is that the tumor gets to a point where it basically asks the body to make more blood vessels, and therefore it has this large blood supply to it. And so there are lots of drugs that actually target this that are called vascular endothelial growth factor receptor inhibitors. We call them VEGF receptor inhibitors, or VEGF targeted drugs, or anti-angiogenics. Okay, so you may have heard of them with those names. And what happens here is that this just calls this overexpression of these receptors basically tells the tumor that they need to grow. And it uses these common pathways that many cancers use, called the MAP kinase pathway and the PI3 kinase pathways. And it just basically tells the nucleus to grow, divide and conquer, keep making more and more tumor. And so the idea is to try and shut this down here so that the tumor shrinks or stops growing. Okay? So that's one of ours. So I just want to point out that these genetic the genetic abnormalities that I'm about to talk about in tumors are actually in the tumor. Okay, they're not the kind of genetic abnormalities that are inherited, like the BRCA gene. Okay, that you can pass on to your children. These are genetic abnormalities that are in the tumor. Okay, and that's important because I get that question a lot. You know, are my children going to have thyroid cancer because I have this mutation? So here is an example of a mutation that is very common in thyroid cancer. It's called BRAF. It's along that pathway that I told you about that allows the cell to grow and divide. And we have drugs that can target this. Okay. Also, many patients will have RAS mutations, which are here. And again, we don't have good drugs for this, but we have drugs that can target things downstream of that. So these are just examples of different mutations that can exist in the tumors. And this is where we can target, right? We have targeted therapy against VEGF receptor, FGFR, MET, all of these things that thyroid cancers commonly have. Okay, so this is basically the alphabet soup, because these are all the drugs that we are able to use for thyroid cancer, or that have been used in thyroid cancer. The ones highlighted in yellow are actually drugs that are on the market that you can get outside of a clinical trial. They're FDA approved. They're either approved for thyroid cancers, such as Sorafenib, or they're approved for other cancers, such as renal cell carcinomas, melanomas, and oftentimes insurance will cover these drugs for thyroid cancer. So they should be taken into consideration. Actually, our guidelines do not limit therapy to Sorafenib only. Okay, you can get some of these other drugs if your physician feels like it's appropriate. Okay, so let's talk about the trials now that you understand a little bit about how these graphs look like. This is the Sorafenib trial, which started in phase 2 trials in differentiated thyroid cancer. And these are trials that had been going on for many, many years. Okay, so many of you have probably heard of this. And then they did a phase 3 trial called the Decision trial. Okay, so you'll probably hear that a lot. And they randomized to either sorafenib or placebo. Why placebo? Why placebo? That was the standard of care. There was really nothing that was approved that we felt worked. Doxorubicin was approved. Nobody really felt like it would be a good option for patients. So the FDA allowed placebo. And essentially, these are the results in a nutshell. Their endpoint, what they were looking for to get approval for the drug, was do patients progress more slowly on the drug rather than on placebo, okay? And these are the curves that I was telling you about. So the line up on the top is the better group, right? The group that did better, they had a longer survival time without progression, okay? Meaning their tumors didn't meet that 20% mark for a longer time than the placebo arm, which is in blue. Okay, but that difference was only about 5 months. And I don't think I have the months on here, but I believe it was around 11 months for the sorafenib versus about 6 months, 5 or 6 months for the placebo arm. Oh, here they are, 10.8 and 5.8. Okay. Okay, and then this was the change in target lesions. So when you look at these two graphs, so this is a waterfall plot for sorafenib, and this is one for placebo. So this one obviously looks better, right? So even though the progression-free survival wasn't that different, you know, these patients, a lot of them had some responses that were within the stable disease criteria, but they had, you know, they really did have decreases in their tumor size, rather than versus the placebo arm, which, you know, a lot of them were on this side of the graph, right, on the top side. So up is not good and down is good. Okay, so basically in summary, the Decision trial, looking at how long patients live so far, we don't really see any differences, but the data are probably not mature enough yet. And remember, patients were allowed to get on sorafenib if they were on placebo, and they progressed. This drug, that patients did have to have, a good number of patients had to have dose reductions, usually for toxicities or dose interruptions, and 19% of patients discontinued due to toxicity. And this drug has been approved since end of 2013. So this is the newest, hottest information. This was presented over the summer at ASCO, and this is the SELECT trial, another randomized large phase 3 trial against placebo. And what this drug showed was a very, very different difference in progression-free survival. So again, these are the ones in blue are the patients who are on the study drug, which is Lenvatinib, 18 months, okay, versus the placebo arm, which progressed at had a median progression of 3.6 months. So very big difference. And so this is a drug that, you know, that many people are very impressed by. However, I can tell you that it's not an easy drug to take. So that wonderful response rate, and it is a really good response rate. This was over 60%. Here we go. Partial response rate of 63%, and 2% had complete responses. Now, I don't know if they had a complete disappearance of thyroid globulin. So again, these are things that you need to know when you're reading these studies, and this hasn't been published yet. But, you know, the drug is not easy to take, so it's not a walk in the park. So really, patients who need this need to be on it. Patients who are progressing slowly, or we can do something different to try and control their disease, probably should hold off on going on these drugs. Okay, it's not yet approved, but I believe it's under FDA review, and I believe probably sometime very, very early next year or at the very end of this year, it may be, we may have a decision. So these are basically what we call class effects. So the drugs within that type of TKIs are anti-angiogenics, and the side effects usually include high blood pressure. These patients have a lot of high blood pressure, very, very, very quick onset of high blood pressure, and difficult to control. You know, they have a lot of fatigue. Again, this is a class effect, and all of these TKIs have caused fatigue. and a lot of weight loss. So those are the major ones. The skin changes, the hand foot, was also seen quite a bit with this drug.
How come the E7080 was compared against a placebo and not against Nexavar?
Nexavar had not been approved yet.
Oh, it started before that was.
Yes, it started in about 2007, I believe. Sorafenib was approved in 2013.
I may be starting on Sorafenib, but I've got follicular cancer with metastases to several bones in the liver. I just had my fourth radioactive iodine, and I had a stroke in 2005, and I'm on high blood pressure medication now. It's stable, so
Right, so that's something that needs to be taken into consideration, right? It's very close monitoring of the blood pressure.
they have to really monitor it.
Yes.
If you go on higher doses of blood pressure medication, then
Oh, yes.
yeah.
Mhm. Okay, so Pazopanib is another drug that's been studied in a phase 2 trial, and some nice responses. The partial response rate was about 49%. Vandetanib was a trial that was done. It was a phase 2 trial, but it was randomized against placebo, and it had a good number of patients. This was done in Europe, and they did see a difference in progression-free survival. Again, the top curve is the Vandetanib, and the bottom is placebo. Selumetinib is a drug that has been used in clinical trials in differentiated thyroid cancer, but this study was actually a really interesting one because what they were trying to do with this drug is to get patients to take up iodine again, patients who didn't take up iodine, to try and restore that. And so they put patients on selumetinib, and they essentially waited, repeated the scans to see whether they took up iodine, and then if they did take up iodine, they continued the drug and received radioiodine, and then had CAT scans. And the patients that did not take up iodine simply stopped taking selumetinib. And so these are some of the responses, which were, some of them were quite beautiful. This is a patient who at baseline sees this is the kind of patient that some of the lesions take up and some of them don't, right? And then after selumetinib takes up a lot of radioactive iodine. So the bright spots are where they're taking up radioiodine. This is a drug that's not approved yet for any indication, and it's still being studied because this was a very small trial. Here's a bone metastasis, so this is really nice, that after selumetinib takes up quite a bit of radioiodine. And so, this is particularly interesting to us because these drugs oftentimes don't work for bone, the TKIs, but this drug works to restore that radioiodine, and then maybe you can treat with radioactive iodine. Okay, so that's the concept.
But you can't get insurance to pay for it.
It's not approved. It's not on the market. You can't get it, period, even if you wanted to pay for it. Yes. Yes.
Is that AstraZeneca that makes that one?
Yes.
And was it, I thought there was some problem with them supplying enough of it.
So, are you talking on clinical trial? So there is a trial that's going on right now. I don't know what the issues are. We're not doing that trial at MD Anderson. It's with patients though that have it's with patients that have just had surgery for their thyroid cancer, and then they go on this before they get radioiodine. Yeah, but I don't know the details of what's going on with that study.
So back on one slide, was the results, it was really favorable for the NRAS mutations, right?
Yes, so I kind of gleaned over that. The patients who had these RAS mutations actually took up iodine better than the patients that had BRAF mutations. So 5 of the 5 with NRAS did, whereas 4 of the 9 with BRAF did, which was very interesting. There was another question.
I just wanted to respond to the comment. My wife was recently screened for the phase 3 trial. I'm not aware of any drug supply issues.
Okay.
Oh, where is that?
Well, it's many centers. She was screened.
Yeah, it's worldwide. You can
Again, it's only
look
for-
it up.
trial
And
only for recently diagnosed phenotypes.
Yeah, and I'm a progressive, so I have a medical science liaison, I work for medical affairs, AstraZeneca. And the study that you're referring to is called the Astra study, and it is ongoing, and there are no drugs for approved. So.
yeah, it may be that what you understood is that you can't get the drug because you can't get it outside of a trial, basically. You have to be on the trial to get it.
The oncologist works at
Oh, okay. Yes.
I do have a question. Last year, I was excited about some of the drugs I was hearing about, including this one. And then on the last day, I went to a session where somebody explained to me that actually doesn't apply to Hurthle cell because why? Because of that RAS, BRAF, like Hurthle cell doesn't have. So can you tell me on these drugs which ones don't apply, as you're going through, which ones don't apply to Hurthle cell?
They all apply to Hurthle cell. And this just had, the Selumetinib, I don't think they had enough patients. I'd have to look it up, but I don't think they had really enough Hurthle cells to say that it doesn't work in Hurthle cell.
I think you were saying that you didn't have that gene that was.
Right, so Hurthle cell usually doesn't have BRAF, and few have RAS mutations. But that doesn't mean that it won't work. This was a very small trial, so it needs to be tested in larger populations of patients to know that. Okay, and let's see. Okay, so Cabozantinib is a drug that is approved for medullary thyroid cancer, and this was studied in differentiated thyroid cancer patients. We did a small trial where we included thyroid and renal cell, and we just published the results of this, and we had some very nice responses. You can see that over half the patients reached that 30% mark. Okay, and the nice thing about this this drug is that for these types of bone metastases, we've seen, which basically are building bone instead of making holes in the bone, we've seen some nice responses. This is just one example that was included in the manuscript, and so we're trying to understand what it is, how it works in bone, and if it works in bone in a larger trial. And currently we're recruiting to that study. But you have to have progressed on another anti-angiogenic to get on the trial because we're using it as second-line therapy. That's the skull, yes. Okay, so BRAF mutations. So people are very interested in BRAF mutations because these patients, you know, the thought is that they do a little bit worse than the patients that don't have a BRAF mutation, and there's not, you know, there's not a huge amount of patients with metastatic papillary thyroid cancer with BRAF mutations that we've, you know, big enough number of patients really that we've looked at, but our sense is that they do behave a little bit more aggressively and probably causes some silencing of some important genes that help you take up iodine in the tumor. And so these patients oftentimes do not take up iodine. So everyone thought, well, okay, well then, you know, this must be, if we can get a BRAF inhibitor, this must be the silver bullet. We just put them on this, and this stuff will make their tumors take up iodine, and it'll make the tumors go away. And you know, yes and no. So it's a little bit like the other TKIs, right? This is not actually a TKI per se, but it's a kinase inhibitor. And it does have some efficacy. So we studied this in a phase 2. This is not published yet, but was presented at a meeting. We divided patients up into patients who'd never been on TKIs and ones who had. And I'm just showing you the ones that had never been on TKIs just because lack of time. But we had some very nice responses here. Patients, about half the patients achieving a partial response. And it's being studied to see whether these patients will also take up iodine. Sorry, I keep moving forward too fast here. Dabrafenib is another BRAF inhibitor. So that other study was with vemurafenib. This one was dabrafenib. And we just published this study. It was a very small, it was actually a phase 1. It was a larger phase 1, which included some patients with thyroid cancer. And you can see that, you know, a fair number of patients had responses to this drug. Okay, so the question is then, that's great, we've got all these drugs, there's lots of choices, but what happens if you get on one of these drugs and you either can't tolerate it because it's just too toxic for you, or it stops working? So the question is, you know, what do you do with these patients? Are they going to be able to continue getting another drug? If you give them a drug that has a similar mechanism, like anti-angiogenics, are they going to continue responding to that drug? And so we didn't know. We wanted to answer that question, so we looked at our own experience at MD Anderson with what we call salvage therapy. And We looked at patients who had just been on Sorafenib because at one point we didn't have all these options. So we had been using Sorafenib but well before it had been approved for this indication. And so we looked at that group of patients that had only been on Sorafenib and had never gone on to receive any other therapy, essentially mostly because they didn't have other options or the patients just didn't want to continue because they just didn't feel well on the chemotherapy. And then we compared it to patients who had gone on Sorafenib and then went on to receive something else afterwards. You can see that group that went on something else did a little bit better than the patients that just stopped after Sorafenib. And then these are the different types of chemotherapies that were used in second line. It was kind of a hodgepodge. So everybody had been on Sorafenib and then went on to something else, but it wasn't always the same drug. So we had patients on Cabozantinib. For example, this patient on Sorafenib had progression, and then we put him on Cabozantinib, had a nice response. So just because you don't respond to Sorafenib, essentially, doesn't mean that you're not going to respond to something else. So the bottom line is you should keep trying to find something that works. This patient had been on Sorafenib and progressed. This is the best response, okay, was progression. Put him on Lenvatinib, the E7080, and had a nice response. This is a patient who didn't have much of a response to Sorafenib, went on Vemurafenib, and did have a response. And so you can see that we believe that these patients need to go on to some other therapy. So what are we working on next? There are lots of things in the works, but we're quite interested right now in trying to see if either radiation or some of these drugs, anti-angiogenics, will work in conjunction with immunotherapy. So trying to get your own immune system to recognize that this is a tumor, it needs to be destroyed. And so, that's probably, where a lot of us are headed in that direction. And so there may be some trials that are coming soon with these types of therapies. So, I think I would encourage most people to consider a clinical trial, and that may not be feasible for everybody. But I still do think that the first thing that should be offered to patients is a clinical trial if it's available. And there's pros and cons to clinical trials, and some people simply can't do it. And sometimes it's not right for some patients. But I do think it should be considered as the first option on the table, right? So basically the pros of going on a trial is that you're going to be followed very, very closely, okay? So, you'll probably get the best care you've ever had in your life because there's somebody who has to be on top of you trying to figure out, are you okay, are you okay, are you okay? And coming back to be seen. You may be able to get a drug that's not yet available commercially. So like those patients on Selumetinib, right? They were able to get that drug. Before it's not even out on the market. But so they may have benefited from that. Of course, some patients may not have benefited from it and may have been harmed by it, so that's a risk. You may be, for altruistic reasons, you may want to consider a trial because you may be helping other people, like the people sitting in this room, understand, whether a drug actually works for thyroid cancer or not. Okay, without patients in these trials, we would never have a drug that's approved for thyroid cancer. So we need patients to go into these trials. And so the cons basically are the unforeseen risks. If there's a placebo arm, you could be randomized to it, although I don't think we're going to have many placebo controlled trials in the future. The drug may not be better than standard therapy, right? So it may be that whatever is on the market right now is better than what we're testing, but we don't know that until it's tested. And then this is the big kicker for most people, is that it's very expensive unless you live where the study is being done. But we see so many patients from out of town. A lot of them cannot afford to come to MD Anderson every month, pay for hotel rooms, pay for flights and things like that. And some trials may compensate you, but a lot of them will not. So it is time consuming. It's an expense. I think if you can afford it, then you should seriously consider it. Also, your insurance has to approve you going on the trial. So even if the drug is free. And this is where a lot of times, we have the willing patient who's very eager to go on the study, and then we find out insurance company doesn't cover trials, okay? So, so that's something that needs to also be taken into consideration. And then these are the other things, is that basically the trial has to be open, has to be enrolling. You have to meet every single one of those criteria to get in, usually. You have to go to the trial center. So a lot of patients ask me, well, can't my doctor at home just administer this to me? And the answer is no. It has to be done at the center where you've enrolled at. And so you do have to, constantly be going back there. The common entry criteria, basically, that you have to have radioiodine refractory thyroid cancer, right? Basically, radioiodine no longer works. You have to have progressive disease in most trials. The AstraZeneca trial, of course, doesn't require that, but usually trials require you to prove that you need chemotherapy. Good performance status, because you have to be well enough to take these drugs. Normal organ function. Most of them don't allow for brain metastases, even if they've been treated. Some do. And then you have to be willing to follow the schedule of visits. And you can go on clinicaltrials.gov to find out whether there's a trial available and where it's available, if it's close to your home or not. So let's talk a little bit about side effects, because these drugs do have their side effects. And I always tell my patients, listen, this is the list of side effects, and this is just a partial list, but you're not going to get every single one of these, okay? This is what's most common, not necessarily will happen to you. But with VEGF receptor inhibitors, those anti-angiogenics, hypertension can be a problem. Again, not everybody has it. You can start spilling proteins into the urine, and this is a problem that may lead to having to take you off of the drug. Diarrhea, ulcers in the mouth or mouth pain, it's usually like a sensitivity to things such as spicy foods, hot foods, things that are very cold. Some things might start tasting funny, very sweet or very salty, or doesn't taste like anything. And so some patients start to really lose a lot of weight on these drugs, in part because of this, but I think probably there's also something happening that causes the patients to lose a lot of weight we don't quite understand. Skin and hair changes. Some of them make your hair turn white. Some of them make your hair curly. So they're kind of interesting. Fatigue is a very common. Weight loss. Your thyroid hormone may need to be adjusted, and so we always need to remember that we need to check the thyroid levels, because a lot of them cause your TSH to go up, and so you might need more thyroid hormone. And then cardiac dysfunction is a rare side effect, but it can be quite problematic.
Does protein in the urine mean kidney malfunction?
Yes, it's a problem with the kidney. So hand-foot skin reaction, that's the big one, okay? We see this quite a bit with the anti-angiogenics, and we can see them also with the selective BRAF inhibitors. It's kind of a range of different types of skin changes. Some of them are peeling on the hands and feet. It can be painful. They can also just be, they can blister and then peel, or they can just be very hard calluses that are very painful to walk on. And so these are things that we need to address early on. A lot of patients just kind of tough it out, and they come back and they're like, oh yeah, I've had this for 2 months. I'm like, well, you didn't tell us, so we can't help you if you don't tell us. We ask patients to get, use soft shoes, so these would not be the right shoes to be walking in. No high heels, things with pressure points. We really want you to talk to your doctor, because we can treat this with, sometimes we just have patients go and have the callus shaved down, and that seems to help. I have patients that kind of maintain that after the podiatry. They maintain that callus nice and shaved with those little ultrasonic machines that I think Sonic Care is the name of it. And then we have you guys put a lot of moisturizer on, and that tends to just really keep things nice and moist and control things. You may need to stop drug, hold for a little while, and maybe decrease the dose until we can find the right dose that works. And then prevention is just, don't cause a lot of friction to the area. That makes it worse. Heat makes it worse. And then we can prevent by putting on a lot of these moisturizers. This is an example. I don't know if you can see it. This is the one that's peeling, and this is more of a callus kind of formation. Here's a few more pictures. This one's much more severe. But so you've got lots of dry skin. Patients tend to just like peel it right off, And so we can try and control that with some moisturizers and basically getting rid of that extra tissue there. Rashes are common. They're basically drug rashes, and we ask patients not to take really hot showers. To try and wear loose-fitting clothes, avoid sun exposure. If you're going to have sun exposure, to use a high SPF. And keep that skin moisturized. These are some examples of drug rashes. So see, this looks very different from the hand foot, right? This is like a reaction to a drug. EGFR receptor inhibitors, this would be the class that Lenvatinib is. Lenvatinib can cause this acne type of rash. And so you can see he's got like these kind of acne on the face. These are a side effect of Sorafenib, Vemurafenib, and Dabrafenib, basically the BRAF inhibitors. You can get these really weird-looking, what I call horns, these little lesions on the skin that have this very kind of dry, pointy thing on them. Those are called keratoacanthomas. We take those off because we do believe they're pre-malignant. You can get squamous cell carcinomas, and those also need to be taken off. With the very selective BRAF inhibitors, the moles can get darker. There have been reports of new melanomas in patients. This is not a common thing in our population of patients, but it's something that we really need to think about. And essentially, I think these patients, if they have a lot of skin changes, they really need to be followed by a dermatologist, because I can't do anything about this. I'm not a dermatologist. I can't, cut it off or spray it down with the cryotherapy. So you do need to be followed by a dermatologist. For mouth sores, we try and avoid foods that bother the mouth. Biotine rinses that you can get over the counter. You can make your own baking soda rinse, and so I've put this in. I don't know if you have the handouts with the information, but I believe this will be available to you, so you can get those recipes if you need them. Diarrhea. I have patients kind of try and keep track of what bothers them, because they eventually learn how to eat things that they can tolerate that don't cause diarrhea. I have them avoid really fatty, spicy, fried foods. They should always carry Imodium with them, and ask, if that's not working, then you need to ask for something else, not tough it out, okay? So these are other options that we can use for patients. And then there's a Metamucil mixture that helps some patients, and the recipe is here. So fatigue, we always make sure that you're not hypothyroid, because that's one of the causes of fatigue. Although for the most part, it's usually not that. It's just that the drugs cause fatigue. And so we ask that you take short naps. You might have to, not work as hard. Maybe it's not a bad thing. And usually a short nap during the day really helps. I think light exercise really helps. Maintaining a healthy diet, keeping that weight up, drinking plenty of water, and taking part in activities that you enjoy or are relaxing. So I want to thank the patients here, because really without you, this slide deck wouldn't exist, right? We wouldn't have all these fantastic results to show you, and we wouldn't have all these options today. So I really appreciate the participation in not only just in the clinical trials, but you being here today to support each other. That's all, yes.
I just wanted to say about the diarrhea, two things. Being that I live with somebody that's on two TKIs right now, Nexavar and Afinitor, and those two together can cause even double some of those side effects that you mentioned. in the food diary, we just found that he is severely sensitive to soybean oil, soy lecithin, and I would encourage anybody who might have to go on those to the first thing, just cut out the soy, and if you introduce it back in and it gives you diarrhea, don't go there.
Yeah.
And,
Yeah, so
that's
see, and there's
share
lots of
with
things though.
patients,
Yeah.
actually.
I have patients that say I just can't eat anything with black pepper. I mean, they're just, you have to keep a
Well,
diary
yeah, the
to
soy
figure it
was
out.
really quite severe.
Yeah.
And then, we've been making our own rice milk at home, which seems to really help a lot.
Okay.
Emolium,
Okay.
Back to clinical trials. If one has got a drug which is toxic, okay, would that limit their eligibility for clinical trials for other drugs?
Just say the second part again. If you have a toxicity to the drug.
If you had a toxic reaction with one drug, would that limit their eligibility in clinical trials for other drugs?
No, not necessarily. If the side effect goes away, if it resolves, then usually you can get on another trial. But I didn't point this out because of I don't have all the time in the world. But here are patients who had toxicity. These last two patients had toxicity to sorafenib. They weren't able to tolerate it, and they actually were able to get on another drug which is similar, sunitinib, and tolerate it. And so no. I mean, you may not have all the toxicities that you have on another drug. So we should always try. And if the toxicity goes away, and if it's not something that's very severe and dangerous, usually you can get back on another trial.
Just to make a comment about the soy, I'm seeing the naturopath who has me on soy lecithin granules for constipation from all my pain meds, and so that's helping me with constipation. So it is a natural laxative. Yeah.
I have read that it has the same effect in the body as certain chemo does, so it was almost like adding certain chemo drugs to the
Yeah.
regimen.
There's somebody here. I see you.
Sleeping problems.
Difficulty sleeping? Difficulty falling asleep? I have a lot of patients with difficulty falling asleep. I don't know that it's really related to the drug. I've always thought it's just, there's a lot going on, or it may be that you just have a lot of anxiety from everything that's happening, and thinking about these things at night just keeps you up, So we try and use things to help patients sleep so that they don't feel just exhausted when they wake up. Mm-hmm. Yes. Mm-hmm.
There's a new study out using Actos as diabetic drug. Are you familiar with that?
I'm not familiar with, the pioglitazone study, yes. The pioglitazone study is specifically for patients who have a genetic defect it's called a rearrangement in the tumor. And so you have to have that particular defect to get on that study. But yes, that's a trial that's ongoing. You in the front here.
I'm curious if you can be on a clinical trial. I've had rheumatoid arthritis for decades, and with some of these, I guess they call them TFN users, whatever inhibitors, can you have a clinical trial and still be on something like that?
You have to basically look at each trial, but probably the majority would be okay with. I don't know exactly what it is which drug exactly that you're on, but oftentimes it's not an exclusion. Depends on the chemo that you're looking at. There's somebody over here. Yes.
Can you go back to the slide with the bone cancer with the two heads? Yeah, that one right there. What is that on the bottom? What was you were talking about that, having to have progressed well on what? What is that?
Anti-androgenics. That's the class of drugs that targets the VEGF receptors, which is basically the blood supply ones. So Sorafenib, Lenvatinib are anti-androgenics. Pazopanib, those are all anti-androgenics.
And are there specific drugs for bone
There of these different in these trials. Are you talking about, or
Yeah.
just in general? I mean, this class of drugs in general doesn't work very well for bone metastases.
Yeah.
You know, it's a difficult thing to look at, and so on this study, we're actually specifically looking at what happens in the bones in these patients, because it's something that hasn't really been kept track of in clinical trials. These are things that we have observed in our own patients for the most part, that they don't work well in bone. And so we were really excited when we saw this. And this happened within 9 weeks. I mean, this is a very quick response. So it's interesting, but I don't think it's going to work very well, it's my opinion, right? In the kind of bone metastases that make holes in your bones. They're called osteolytic bone metastases.
Well, that's what I was curious about, because I'm on a clinical trial phase 2 right now. It's called MEK 162, and it's stopping my tumors from growing. But now what happens? Like, I'm just going to have these holes in my bones, and I have a rather large one in my hip. I have in my rib, in my spine, in my shoulder blade. Like, what's going to happen with these bones now? So I'm just curious if there's any. Like, what do you do for a patient like that?
Yeah, so I mean, if you're on a trial, you can't. Usually you can't do any type of localized therapy. It depends on the study, but with patients like that, where they have metastases that are either bothering them or they're just in a bad place, we try and radiate them to stop them from growing. But you can't make them. Once you have that hole there, it's not gonna fill in with new bone. It's a matter of just stopping it from continuing to do that. So you don't do anything about it. If it doesn't hurt, you just watch it.
I'm violently allergic to Zometa and Eva. Is there anything I can do about that?
No, I think I don't know what your allergy is, but I think once you've tried it and it's
Terrible shakes and
yeah. So that happens with the not the denosumab usually, with the Zometa. After the first several infusions, that usually goes away. So I don't know how many infusions you've had, but it does tend to go away after a while, the flu-like symptoms.
I've only had 2.
Yeah, I mean, I've had patients where they used to say it's after the first one, it goes away. I've had patients where they've had, for the first few infusions, they've had the reaction and then it goes away.